Thank you. And this is my topic. What are the limits of the anatomic total shoulder in primary shoulder arthritis cases? This is sort of wrap up of what was said during the entire session. So I try to go through it. As already alluded by David, the history of the modern prosthesis starts with Charlie, who described this monoblock. At the beginning it was a hemiarthroplasty, and then he published also the results also with this cemented all polyglenoid. Since then, the use of the total shoulder replacement was spreading around the world. At that time, the indication, I was a young boy too, David, at that time the indication were, for this primary shoulder arthroplasty, the indication was shoulder pain, pain in the night, with inability to perform daily activities, chondral bone in the glenoid, with a good rotator cuff, some inflammatory arthritis, and look at this, it was a few years ago, it was written by Charlie. A posterior humeral head subluxation, we were discussing in the first part. So we need to understand that we are the ring of a long chain of evolution, and looking at the history is helping, and forgetting history then is leading us to other mistakes. So this was where we were in the late 70s. Let's go now to some data in the recent time. This is the proportion of shoulder replacement in the US, and you see that the US, they got from the FDA approval in November 2003, and you see the switch from HEMI, that is the blue line, strongly declining, and then the green line, that is the reverse, climbing up, and let's say the purple, it is the anatomic total shoulder that is reaching a sort of steady state. This is why we started to develop new design, because we were not that happy with this anatomical design. We had the first generation, the monoblock, then the second generation with the modular heads, then the third generation, changing the offset, the inclination, and so on. Finally, more recently, as described by Professor Porcellini, the bone-preserving and potentially convertible design. Was this helping us? Let's stay always to the numbers. The current and future numbers about shoulder replacement. Let's stay in Italy. This is the Italian registry, 2020. It is the most recent. And you see that only 5% were anatomical replacement in overall implants, 5%. 4.1 were election, 0.8 for trauma. For trauma, almost disappearing there, and some election, but not that much. But even more interesting, look at the numbers on the right side. This is a seminar in arthroplasty by the Journal of Shoulder and Elbow, quite recent, 2020, and you see that overall shoulder arthroplasty utilization will increase 122% in about 20 years or so, so increasing very much. And anatomic total shoulder and reverse total shoulder will increase 50%, 49, for anatomic, and 122 for reverse total shoulder. So anatomic is not increasing as much as it is expected for reverse. Why that? Let's go to the revision rates and the problems related to the implant. This is a big study done by the French group, Pascal and Gilles. They did this observation for a long time, 20 years of French experience, so something that is significant in the history of the total shoulder replacement. They had, out of these implants, speaking and focusing only on the total shoulder arthroplasty, these are 2,500 roughly, they revised about 10%. Overall revision rate was, all the prosthesis was 6.5. Total shoulder revision for glenoid loosening was over 40%. And revision to a reverse was 50%, so quite high. And Gilles was reporting this, very much reporting the effect of the superior tilting with the rocking horse, subsidence of the implant because of the cement failure, and the posterior tilt. This was leading Gilles to describe something that we know very well about the different deficiency of the bone in osteoarthritis with the ABC classification that we know clearly, and we started thinking about this nightmare that is starting so early. Earlier this morning with Philippe Moroder, we understood that it is something that has remote roots developing the issue in the shoulder. And so it is really a nightmare about this. Finally, with this, there are many studies there demonstrating that the erosion of in arthritis, also in primary arthritis, is much more developed in the posterior and posterior inferior glenoid part of our implant. This is why the classification by Gilles was expanded, not only A, B, C, but then we started thinking about some hypoplastic. The B2 is not all, and this is a courtesy from Gilles personally. The B2 glenoid was described that is the consequence of the static posterior subluxation, secondary erosion of the posterior part of the glenoid, where you need to have the proof of a secondary posterior wear with the paleoglenoid, a humeral subluxation, and the retroversion that is switching from up to 60% degrees. So when you have this condition, it is a major issue when you are going to plan to restore that glenoid in an anatomical fashion. And finally, more recently, we had a modified watch classification introducing even not only the B2 and B3, but the C with the glenoid retroversion degrees not caused by erosion, this is dysplastic, and D with the glenoid anteversion or anterior subluxation. So glenoid is the game maker for our implant in anatomical prosthesis. So evaluation, CT scan is crucial. We need to have a three-dimensional evaluation, evaluate also the inclination, not only the retroversion, that is important, because we need to assess the shape, the retroversion, the inclination, and humeral head subluxation, and the erosion. That means it is moving the central rotation medially. So especially when we speak about lateralizing or just restoring the joint line. So we need to understand all of this. So studying the glenoid morphology, including the scapular position, that is the near focus for the future, also in the sort of PSI or assisted surgery, is so important. Then what to do in this such complicated situation? We have had some options described in the literature: eccentric reaming, posterior bone graft, augmented glenoid component, reverse, other, or doing nothing. Again, to the history, we tried, Joe, I and Nodi did it, changing the anteversion, the version of the humeral head, but it did not work. He was not happy with the outcome. But an interesting thinking about this is coming from Joe himself and Ken Yamaguchi, because sometimes when we have this static posterior subluxation, maybe we want to change what Mother Nature is doing. So maybe that just preserving some of the wrong, in our studies, wrong perspective of the retroversion of the posterior subluxation, the offset and so on, we should eventually leave it in that position, but it is just a postulate thinking. Let's go to the results of a total shoulder arthroplasty. Indication or technical failure. Let's go step by step. This indication, they seem good, but if you have a rotator cuff failure, then it is a problem. Excessive glenoid retroversion, then it is a problem. Static posterior instability, it is a problem. And all of these, they lead to implant failure. Let's go to the results with survival at 10 years. In primary arthritis, this is a study reporting 90% at 10 years. With the B2 glenoid, however, 6.3 revision. Post-traumatic arthritis, 33%, because of rotator cuff failure and tuberosity malposition, so it is a poor indication sometimes. Rheumatoid arthritis, survival, 92%, similar to primary arthritis. Shoulder fracture, tuberosity malposition is playing the game. Head necrosis, 75 survival. So here you have the numbers of what can be the indication and the options. You will listen to the other presenters before. We have several options. When you have several options to solve a problem, it's because we don't have the perfect one. This is the only solid point I have in mind. You may have the augmented glenoid, and you can augment by bone or stepped glenoid. Revisable hybrid glenoids, they are coming out now using a blend of metal and poly, very charming in this phase. or rimming that is anyways not enough when you have a severe retroversion. What about the B2 glenoid and what does the literature says? It is interesting. I just put 2 articles because you can demonstrate what you want with the literature if you just look with 1 eye. Let's look with 2 eyes or even 4. And you can see here that some authors are reporting good early results with all-peg anatomic arthroplasty, while Jill Walsh in the B2 literature, in the B2 glenoid for the literature is saying, I'm not happy with that. So look at the numbers always very carefully. Take-home message after this rope-up condition. Main complication, anatomic shoulder arthroplasty is glenoid loosening. This is clear. This is especially true when dealing with B2 or B3 glenoid, when you have this posterior erosion. Most shoulder surgeons do not recommend anatomic total shoulder arthroplasty when arthritis is associated with this posterior erosion. However, we need further long-term follow-up studies to confirm this orientation, because it is a reasonable feeling, but we need to confirm it perfectly. New prosthetic design are under investigation for mid-long-term outcomes, and you have seen some of them before. Anatomic total shoulder arthroplasty is prohibited when the rotator cuff is not functional and or irreparable. Anatomical shoulder arthroplasty is indicated and recommended for the treatment of primary shoulder arthritis associated with the A or B1 glenoid. It is a good indication with a good cuff. When it is not indicated when you have a C or D glenoid. I hope this was a good rope up. Of course, I'm not clarifying anything, but still keeping our eyes open on the problem. Thank you very much.